Welcome everybody to your Haemoglobinopathies awareness training for University Hospitals of Northampton. My name is Claire Stockley. I'm a clinical nurse specialist and I look after patients with haemoglobinopathy conditions across Northamptonshire. We have a team of paediatric and adult nurses who look after this diagnosis, and we cover both Northampton General Hospital and Kettering General Hospital sites. Our roles were created in 2017 and our patient caseload has steadily grown. We now look after over 300 patients, both paediatric and adult, with this lifelong inherited condition. Haemoglobinopathy disorders are a genetically acquired condition. They produce an abnormal structure to your blood cells. They are an inherited single gene disorder, which we'll go through later. And sickle cell disease is actually the most common inherited genetic condition across the world and a massively growing caseload in the UK. Haemoglobinopathies include thalassemia, sickle cell disease, and inherited rare anemias. Looking at the inherited genetic patterns, both parents need to be carriers of the condition. That could be thalassemia or could be sickle cell disease. This adds complexity because parents can hold different forms of sickle cell disease, as there are a number of different types. But for example, here, if we look at a patient and their parental background, each parent here would be a carrier. So they would have A hemoglobin and S hemoglobin. The mother would also have A hemoglobin and S hemoglobin. Therefore, every pregnancy from this affected couple has a 1 in 4 chance of producing a child with the condition in every single pregnancy. Since 2007, haemoglobinopathy disorders have been added to the newborn blood spot screening programme. This was included to support these patients as there is an increased risk of complications in early childhood. Across the world, the highest risk of death with things like sickle cell disease is the ages of 0 to 5. Therefore, newborn blood spot screening added these haemoglobinopathy conditions. This supported us in identifying and educating families early. This helps us to identify and educate families early and provide support required. In thalassemia, the use of folic acid is there to support the body's system in the production of the red blood cells. And in sickle cell disease, patients are required by day 28 from birth to have started on regular penicillin prophylaxis and folic acid. Penicillin B to prevent complications of infections, and folic acid to help support the production of red blood cells. Another key element to the care of sickle cell disease is to ensure that patients are fully vaccinated. Children will follow the usual NHS immunisation schedule, but on top of this, patients are requested to have the annual flu vaccine and also asked to have a PPV 23 pneumococcal vaccine every 5 years for life. This is to prevent complicated chest infections which can lead to chest crisis. So why and how has the care improved? Back in 2008, there was a confidential inquiry into patient deaths across the NHS with sickle cell disease. This highlighted huge variations in care across the NHS and the complications of patients presenting to emergency departments and how their care was undertaken. Following this inquiry, NICE created in 2012 national guidelines for the care of these patients. This includes the management of an acute painful crisis. The inquiry heard that the awareness of sickle cell disease and other haemoglobinopathies amongst healthcare professionals was low, and that patients were regularly having issues when attending acute services. Therefore, this is why we are here, to try and learn and improve these outcomes. As we discussed earlier, Thalassemia is a similar genetic inherited condition. And again, from this visual representation, it shows that each baby born to affected parents has a 1 in 4 chance of having thalassemia. It's also important to understand people's carrier status. To support this, if you feel that you could be affected by one of these conditions, if you attend a GP appointment and request that your GP completes a haemoglobinopathy screen, not a sickle cell solubility test, but a haemoglobinopathy screen test, this should identify your carrier status. As in thalassemia, the body produces no red blood cells. This is a disorder of quantity. Very little quantity, little or no red blood cells are produced. The only support for this is blood transfusions. If a patient's hemoglobin is chronically low, this can hugely impact their ability to complete daily tasks and affect their growth and puberty. Patients with very low hemoglobins or who produce no red blood cells require regular blood transfusions. This comes with complexities that we will discuss later, but this does impact on their life because it means hospital visits to have a blood transfusion every 3 to 4 weeks. Those having blood transfusions and requiring them, once they have started, need them for life. The only cure for thalassemia is a stem cell transplant. The Thalassemia Society UK have created standards for clinical care for children. This includes the guidelines for blood transfusion, care around iron chelation, and care around supporting families with this condition. So we've talked briefly about red blood cells, and in thalassemia, it's the lack of production of them, so quantity. In sickle cell disease, it's quality. So the normal cycle of a red blood cell is around 120 days. In sickle, this can be anywhere between 10 to 30 days. Therefore, red blood cells are constantly being reproduced by the bone marrow, but they are very fragile. This fragility causes sickling. Okay. The spleen is your filter system for your red blood cells. It acts as a colander or a sieve to remove those cells. When those cells are damaged and they're constantly being broken down, they damage your spleen very quickly. We treat patients with sickle cell disease as asplenic. We treat them as if they have no spleen. This is also part of the reason that we put them on prophylactic penicillin V to protect them, because your spleen also acts as your first line of defense against infections. And in patients with sickle, this is something that isn't working properly. Patients therefore in sickle have a low hemoglobin. A normal hemoglobin is about 120 to 140. The majority of sickle patients can sit between 70 and 90, some as low as 50s and 60s. Again, as we mentioned previously, the only cure for sickle cell disease is a stem cell transplant. Okay, so what causes a sickle cell crisis? Blood moves all around your body, from the tip of your head down to the bottoms of your toes. These biconcave discs should be able to access all of your blood vessels. In sickle cell, this does not happen, and these fragile cells change into this C shape. The easiest way to understand this is if you had a pair of tights and you had an apple, that round, flexible shape should move very easily down to the bottom of the tights. If you had a banana and you tried to move that down a pair of tights, due to its shape, it would snag and could easily get stuck. In blood vessels with sickle cell, this is what occurs. But what causes it? It's a very complex condition. Infection, stress, cold weather, extreme heat. Dehydration causes the thickening of your blood. Exhaustion and extremes of temperature, which unfortunately are common in the UK. And cooling winds can be an issue, because on warm, windy days, we don't wear the correct clothing. And this cooling wind can actually cause the vessels to constrict, and the reduction of the size of the vessels increases the chance of these sickle-shaped cells getting stuck. As we've talked about, there are a number of precipitating factors. We try to encourage patients to hydrate themselves really well and drink to 1.5 to 2 litres a day. This can be complex when you're at school and work because you are not necessarily encouraged to have multiple toilet stops. Infection is another trigger, and this is part of the reason that patients are on penicillin prophylactically, and patients are able to increase their penicillin to treatment doses if they need to. Fatigue and trauma can also be factors, as can stress, especially around exam time at school. Too much physical activity, although we encourage patients to keep physically active to keep their lungs and their hearts healthy, extreme physical activity, especially in heat, can cause issues and dehydration. Pregnancy adds an extra level of pressure on the body's systems, and an already anemic patient in pregnancy, this can tip the balance too low and be too much pressure on the body systems. Any patient with sickle cell disease will be referred to a haematologist and an obstetrician as part of their care for pregnancy. Patients are advised to avoid excessive alcohol and smoking, as again, alcohol causes dehydration and smoking damages blood vessels. As we can see from this visual representation, blood should be able to flow freely through vessels. As you can see here, you have a clump of sickled cells in the top level, and this is causing a lack of oxygenated blood to flow past this blockage. The easiest way to explain this is when you kneel down on the floor for a prolonged period of time and get up, and you'll get pins and needles in your leg. That feeling is the lack of blood flow to the lower part of the limb. That pain subsides quite quickly, but in sickle cell disease, that pain continues and continues because the oxygenated blood is unable to flow to that area, and the tissue beyond the blockage is being starved of oxygen. Pain receptors are becoming very acute, and this pain does not stop. How do we treat sickle cell disease and support these patients? The traditional treatment for complex sickle disease and those patients that attended regularly with crisis was transfusion. The process of transfusion, as is in thalassemia, is to support the body's bone marrow. But in sickle cell, we use transfusion therapy differently. We use it to try and water down the patient's own blood. So their bone marrow is functioning, they are producing cells. But if we top them up regularly with somebody else's blood, their bone marrow doesn't need to produce as many sickle cells. And what we aim to do is to reduce their sickle percentage in their blood to below 30%. This, in theory, turns them into a carrier status and allows us to calm down the damage the sickle cells are causing throughout the body. We do have to be mindful, though, because each transfusion of blood is a neat shot of iron. Our bodies are extremely good at recycling iron, and we do not lose it very quickly. Once a patient has received between 10 to 15 blood transfusions, which can only be 12 to 18 months sometimes if you're having them every 4 weeks, is that the iron can build up in the body. The main places the iron deposits is in the liver and the heart, and this unregulated can lead to multi-organ failure. Therefore, we closely monitor these patients that are on regular transfusions, and we ensure that the iron levels in their body are not too high, and we use iron chelation to try and support this and allow the body to excrete the iron. Patients with sickle cell are also at an increased risk of stroke. This is part of the reason that newborn blood spot added haemoglobinopathies within its testing parameters. From the age of 2 years of age, patients with sickle cell disease are scanned annually. This is an ultrasound scan called a transcranial Doppler. It's an ultrasound scan with the jelly and the wand, as you would have for many other procedures, including pregnancy. This is a non-invasive test and can be done in a clinic setting. Patients are scanned annually as part of their annual review, and this is to check the flow of the blood vessels on either side of their brain. next to the left and right hand side of your face, your skull is thinner, and up to about the age of 16, you should be able to ultrasound scan these vessels and make sure that the blood flow is even and not too high. If the blood flow is high and identified as a risk, then the patients will start on a drug called hydroxycarbamide, or they could start transfusion to keep them safe. A stroke in a child should be a never event now if they are correctly monitored. As I mentioned previously, hydroxycarbamide is now the first line treatment for sickle cell disease. This is recommended in the NICE guidelines. It's now recommended nationally for all patients with HBSS sickle above the age of 9 months. We do use it in patients with HBSC disease, but at lower levels and only if they have complications of their disease. Hydroxycarbamide is a very clever drug. It increases a thing called fetal hemoglobin in the blood. It is a chemotherapy drug and does need regular blood monitoring. This fetal hemoglobin is able to carry a lot of oxygen and acts as the antidote, in theory, to the sickle within the patient's blood. If patients can tolerate hydroxycarbamide, this can reduce the frequency of painful crisis, stroke, and organ damage. It's usually very well tolerated, and we have a large number of patients across Northamptonshire on this treatment. As part of paediatrics and adult services, there are care plans available to support patients. Simon Dyson developed a care plan through the Unit of Social Study and was very interested in the care and support and health inequalities of sickle cell and thalassemia. He produced both a school care plan to support patients in ensuring they were kept safe at school and teachers were aware of their condition. There is also a care plan for education and employment for universities and as patients move into employment. It discusses employment law. As we've discussed, patients may need to take time off for clinic appointments. This is important for their well-being or for treatment, for example, blood transfusions. And schools and employers having an awareness of this hugely improves patients' quality of life. This is a patient from University Hospitals of Leicester. This patient is a young person who has moved between paediatrics and adult services. This reflects the care that we are able to give across Northamptonshire, but also it's important to see how that person needs to be supported and what the key elements are.
Sickle cell disease, it's like a blood disorder where my red blood cells aren't the right shape and they get stuck, which causes things like pain, infections and other complications like that. I can miss quite a lot because I've missed a bit of college already. I think I missed a whole term, so it's really hard to go back and then catch up with all the work. I have to take regular medication every day because they help me to not have any crisis. So I have to take things like hydroxyurea, penicillin, folic acid, 3 of those every day. And I have to remember to take them. It depends on the pain. Like if the pain's in my legs, I can't walk and I can't stand up, so I can't go to college. Or if it's my back, I can't stand for ages. Or if the pain's really bad and I can't cope with it, I can only cope with it, say, by lying down and taking medication. I can't be in college because of that, and I can't concentrate either. I get pain, I'll say, every couple of weeks, maybe months. Sometimes it varies, yeah. And sometimes it can be a small pain. If I take medication at home, it will go away after a couple of hours. Sometimes it can be a great pain that no matter what I take, it's not getting any better, or it gets better after a few hours, it comes back, and then I have to go into hospital. Sometimes it's really difficult when I come into hospital and I'm with people who don't understand what sickle cell is, how to treat me, and there have been occasions where I've had to wait long hours for my medication, and it's really hard because if I tell like a nurse I'm in pain, where's my medication, they'll be like, oh, it's coming, but they're not helping. I think sometimes they don't understand how bad the pain is, because they don't know how it feels like to have so much pain. So they just think, oh, we'll get you your medication, but it's not that important, but it is. So I've had to wait ages, and I've had doctors who can't make up their mind about what medications to give me, which is really hard, and I've had to tell them what medication I want and stuff like that. Places like Ward 27, they treat me quite well there. Sometimes I can come in straight away, get my medication, take me to the ward, and then they kind of monitor me on there. After having a few complications, Libby's been helping me put things in place so that people understand that I've got sickle cell and I need medication as soon as possible. Things like cards to give to people, to tell them what to do, and things like summary sheets about me and what to do, how I feel and how to react and things like that. So it's been helpful. If I'm in a lot of pain and people are trying to ask me questions, sometimes I can't answer them because I'm in pain. And I've noticed as well, I get asked the same questions every day. Well, not every day, but every time I come into hospital. And I think it would be better if they kind of knew me and they had my notes, where I live and things like that. Because sometimes I can't communicate. And I think maybe that's something that needs to be sorted out as well. I spent maybe 6 months or to a year not being in hospital, which is a goal. They understand that I have to get my medication as soon as possible, and they kind of talk to me as well. It's better when the nurses actually come to you, stand by your bedside and explain to you what's happening, when it's going to happen, that they've called a doctor, that the doctor's on their way to see you, that they're getting the medication ready. That's when I know that they're really trying hard, and it's really nice to see that they're putting the effort in. For me, the best thing that can happen is if everyone just knows what sickle cell is and how to treat it.
Please find the references mentioned during this training session for further reading and reflection. Thank you for your time.